Good morning, everyone.
Good morning.
Good
We can
morning.
begin good morning in 2 minutes, okay? Okay, good morning, everyone. Thank you for being here. I hope everyone had a very nice 4th of July. We deserved to rest once in a while. So let's start with a little bit of introduction. I try to put together this presentation for this year. Um, some things are similar to last year, some of them are not. So this is a general information about the schools of thought of mental diseases. They take into account biological factors and psychosocial factors. And as because we're doing a review today, usually we mention some of the factors that are related with mental health that have to do with specifically structures. That is the biological basement, right? Maybe the biological psychiatric or biopsychiatric approach is understanding mental disorders due specifically to brain structures. But on the contrary, psychosocial psychiatric based the factors of mental health disorders on psychosocial problems, specifically that they have to do with the outside, the environmental, um, like, for example, domestic violence, sexual abuse, poverty, or any other type of adversity that the patient could have. So I just want to mention that so you can take that into account, that usually when we talk about neuropsychological, neuroenvironment, biological or genetic factors as part of the etiology of the mental disorders. In general, there are 5 mental disorders that have a very similar genetic background. Those are the ones that has to do with the genes of calcium, specific autism, ADHD, bipolar, major depression, and schizophrenia. It seems like these type of calcium channel gene, being 1C or B2, are linked to mental health disorders. And that is one of the genetic factors for these disorders, okay? It's not only that one. So sometimes we ask ourselves if epigenetic is important, or only the genetic is important, or only the environmental factors are important, or if we do have sex linked modifiers. So mental health disorders are very complex if we are talking about etiology, and almost every single one of these factors, they can interact for different types of disorders. So it's not like as easy as a Mendelian inherence, it's a little bit more complicated. This is just to talk about a little bit about and review what you learn in patient encounter about mental status exam, where you, since the patient came in walking into your office, you see the appearance and the behavior, the way that the patient talks, the mood, the effect, the way he processes ideas. Any perceptions of those are part of the mental evaluation of a patient, and also taking into account the speech process, the content of the thinking, the orientation in person, place, date, and time, memory, if it's a short-term, long-term, all that makes you have a very good idea of the differential diagnosis. So let's start right now with neurotransmitters. Neurotransmitters, I try to do this little chart of review and reviewing one of the first activities that we had during our lectures was to relate the neurotransmitters with their role in the disorders. I took away some of the neurotransmitters here that has to do with neurology. So I took away epinephrine, I took away also histamine, I took away others. So I just left dopamine, serotonin, norepinephrine, GABA, and glutamate. So starting with GABA and glutamate, because they have opposed functions. GABA is an inhibitory neurotransmitter. Glutamate is an excitatory one. GABA, if you want to relate GABA to any of the disorders that we study, I will relate it with anxiety disorders mainly. And of those, GABA is going to be very low in generalized anxiety disorder and panic attacks and panic disorder, and also in OCD. Remember, OCD was taking out of the anxiety disorder. Is a different type of mental disorder right now, based on the DSM-5-TR. Glutamate is an excitatory neurotransmitter, and it's going to be elevated in bipolar disorder and in OCD. If we go to talk about serotonin, serotonin is going to be found low in major depressive disorder. Remember that when we talk about major depressive disorder, it's not only serotonin, other neurotransmitters are going to be found low in major depressive disorder and in some other mood disorders. It's also low in panic disorder and in generalized anxiety disorder. Okay, if we compare serotonin levels in generalized anxiety disorders with the levels of norepinephrine in the same disorder, it's going to be contrary. Generalized anxiety disorder has low levels of serotonin, but very high levels of norepinephrine. And norepinephrine has to do with attention, arousal, and anxiety disorders. So it's also one of the most important neurotransmitter that is elevated in PTSD and also in panic disorders. I reserved for the last place, even though it's in the first place here, dopamine neurotransmitter. So dopamine neurotransmitter has to do with the reward pathway, has to do with substance abuse disorders, with schizophrenia. And when we talk about schizophrenia, we said that we have positive and negative disorders, being dopamine elevated for positive disorders and decrease for negative symptoms. Elevated for positive symptoms and decrease in the case of negative symptoms in that patient. And we also said that positive symptoms has to do with elevated levels of dopamine in the mesolimbic pathway, and dopamine low levels in the mesocortical pathway has to do with negative symptoms. So I think, and I find very useful this chart. Please make sure if you want maybe to add any other disorders here or any other notes. We also talked about something that's called the states or episode, right? So we talk about this when we talk about bipolar disorders. And bipolar disorders are mood disorders, part of the mood disorders. And they can have hypomania, mania, psychosis, depression. In the case of mania and psychosis, serotonin is going to be the number one neurotransmitter that makes a big difference between mania episode or mania state and psychosis state. Because in mania, serotonin is going to be low, but in psychosis, it's going to be high. Of course, the other neurotransmitters that are listed here are very similar on both states. Okay, so if we want to make a better summary of what are the clinical correlations, for example, for each one of the disorders, I try to do this slide for you in order to remember, for example, starting in the mood days, day number 1, MDD, major depressive disorder, the pathophysiology involves the reduction of serotonin levels in the synaptic cleft, and maybe we can use as treatment a selective serotonin reuptake inhibitor as the best treatment maybe for mood disorders and specifically for MDD. In the case of bipolar disorder or OCD, glutamate is one of the neurotransmitters that we can use, maybe inhibiting the receptor or being antagonist to the glutamate neurotransmitter in order to treat bipolar disorders and OCD. But with that being said, remember that glutamate antagonists are not the first line for these two disorders. I'm just using this as an example, how neurotransmitter can be correlated for treatment or clinical disorders, okay? In the case of schizophrenia or bipolar disorder with mania, we know that if we have very high levels of dopamine, especially in positive symptoms for schizophrenia, we can treat it with antipsychotic of second generation because those antipsychotic are going to be antagonizing receptor of the dopamine number 2 or D2 receptors for dopamine, and it will have a better treatment for patients. Antipsychotic second generation, they usually have lesser effects. They do have secondary effects, but lesser effects than antipsychotics first generation like lithium. And also in alcohol withdrawal, we talked about the use of benzodiazepine because benzodiazepine are using the GABA receptor, and we can use benzodiazepine to treat acute withdrawal of alcohol. Remember that GABA is an inhibitory neurotransmitter that is also used by ethanol. So ethanol is one of the main depressor of central nervous system. Okay, so just reviewing the dopamine pathways for dopamine rewards pathway. We have four of them, but the most important ones for schizophrenia are going to be the mesocortical one that goes from ventral tegmental area to the prefrontal cortex and the striatum. And this pathway is also the one that is going to be responsible for the negative symptoms in schizophrenia, and dopamine levels are going to be low when the patient presents negative symptoms. The mesolimbic pathway is very important, not only for schizophrenia and positive symptoms with high levels of dopamine from the ventral tegmental area to the nucleus accumbens. It is also important as part of the food reward pathway, and we're going to see it in binge eating disorder and for bulimia. It is very important for substance abuse disorder like alcohol and cocaine disorder. okay? The nigrostrato that goes from the substantia nigra to the stratum is basically a motor pathway, and it's going to be implicated in Parkinson's disease. One of the side effects of antipsychotic is going to be tardive movements, and that has to do with low levels of dopamine in the nigrostrato pathway. So antipsychotics, because they reduce the levels of dopamine, not only in the mesolimbic, they can also reduce the levels of dopamine in other of the pathways, and that's why with antipsychotics, we have secondary effects. And the infundibular that goes from the hypothalamus to the hypophysis, it's the one that regulates prolactin, and it is implicated in reproductive dysfunction and also hyperprolactinemia. So patients with hyperprolactinemia are going to have problems with fertility.